All right, Resuscitation 101. Let's get started. We're in the new world where a patient rolls in, they're in extremis, and their life is in your hands. Game on. Are you scared? Truly, you should be. This is a huge responsibility where the rubber meets the road. You know, if all that information you put in your head can be acted on efficiently and effectively in an emergent situation. And hopefully, you can do it and make no mistakes. The goal of this course is to provide you with some concepts and tips to keep you in control of the situation so that you can do your very best when the time comes. Recurrent themes throughout this lecture series are the ABCs, reversible causes first, emergency versus urgency. This is critical. Emergency in this situation means that you have to do something immediately or the patient may die. In this case, you do your best. Truly, you can't make it worse. If it's true that the patient would have died without any intervention, you really can do no wrong. You can only do better or worse, but you truly can do no wrong because you do what you can. Urgency means you have time to avoid errors by thinking before you act. Urgency is clearly more of a challenge. It's important that you never act on a patient as if it's an emergency when it's truly an urgency. Remember to check the responses to therapy. This is essential. It guides everything you do. And you need to search for clues, often seen in the vital signs or unexpected responses to therapy. Let's start with the ABCs. The ABCs are the key to control in my mind. It's a methodical assessment which gives you a place to start. You keep the patient alive. That gives you time to think. You have time to take control of the room, and you can move forward from there. If you can't handle the ABCs, well, if all else fails, you know ACLS, right? ABC stands for airway, breathing, and circulation. I like to use the traffic signal model for this, just so I can rapidly assess what I'm thinking about each of the components. The stoplight designation is red light means you need an emergent intervention. Yellow light is a threatened component, meaning you can complete the primary survey and come back to it, but it's definitely going to need to be addressed. Green light means that's secure for now and you can move on. An example of a green light for airway is when a patient walks in and you say hello to the patient and they say, "Hello, doctor." Clinical clues for a green airway are someone is sitting up, phonating normally. I like to tell people to try the AEI test for patients when you wonder about what's going on in their airway. If you do it yourself, say those letters, A, E, I. The A you use the front of your mouth to phonate the A. The E is more of the soft palate. This is the classic hot potato voice that you see with soft palate swelling. I clearly tells you what's going on with the chords. The I comes from putting the chords together tightly. If the patient cannot clearly phonate the I, you should be concerned that the chords are involved. You also want to make sure that there's no obvious neck or oral cavity abnormalities. An example of a red airway is the unconscious patient. The approach to the unresponsive patient is to look at them and say, is the patient breathing? If the patient is not breathing, you need to check and see if there's a reversible cause. Reversible causes of apnea include airway obstruction, cardiac arrest, and Narcan deficiency. It takes less than 30 seconds to sort this out. If a patient is apneic, you reposition the head and look, listen, and feel. It's not uncommon that the tongue actually obstructs the airway in an unconscious patient, and you can fix this by repositioning the airway or using a nasal trumpet. Then you bag the patient. When you bag the patient, you both have therapeutic and diagnostic effects. You help the patient breathe and support them. In addition, if you're unable to bag the patient, you have a good sense that that patient actually has an airway obstruction as the cause. It's good to know if the patient has a gag reflex because right then you can just move on to intubation. Then you want to make sure you check the pulse. If the patient is apneic and does not have a pulse, you need to immediately take action. Do CPR, then check for a reversible cause, such as VTAC or VFib. So checking for reversible causes include positioning the head, look, listen, and feel, place a nasal trumpet if it's handy, attempt to beg. If you cannot beg, consider management for airway obstruction. And there's no harm in providing some ventilatory support here. Then hand off that bag valve mask and check the pulse. If you don't have a pulse, begin CPR. Then check for a shockable rhythm and treat appropriately. If the patient does not have a gag reflex, consider a Narcan deficiency. Then plan for intubation if that doesn't seem to be the problem. A threatened airway, again, a dangerous one. The yellows are truly dangerous. You have a patient who comes in, and now you have to really think. He's awake, and this is what his airway looks like. Do you intubate immediately? He's obviously got a threat. I mean, you just have to look at that tongue to know how difficult that might be. Do you do an emergent cricothyrotomy? Well, not sure that would be entirely wrong, since this patient has an obvious upper airway problem and you could access the airway through the neck. But is that absolutely necessary at this time while the patient is awake? Yellow means you have time to think. Risk assess. Determine if the problem is reversible or progressive. This leads to error reduction and a best approach. All right, you've taken care of the airway. Don't forget the traffic light designation. It might seem a little bit remedial, but again, anything that is easy when the situation is hectic can really help you to feel more grounded. So you do a rapid assessment of the A, B's, and C's, designating them to red, yellow, or green. Either take action, move on, but definitely plan reassessment. Okay, see you next time.